Hi, welcome to the second part of the second continuity of our discussion. So, the second question in the first division will be: was prognostic balance maintained as the study progressed or not? So, to what extent the study was blinded? So, blinding it is the optimal strategy for maintaining prognostic balance. So, if randomization succeeds, treatment and control groups begin with a similar prognosis. The randomization, however, provides no guarantees the two groups will remain prognostically balanced. So that is why you do blinding. So it is the optimal strategy for maintaining prognostic balance. So, what are the five groups in a clinical trials that will ideally remain unaware of whether patients are receiving the experimental therapy or control therapy? So, the five groups are: one will be the patients to avoid placebo effects, second, clinicians to prevent differential administration of therapies that affect the outcome of interest, that is called as co-intervention, and the third will be data collectors to prevent bias in data collection. Fourth, the fourth group will be the adjudicators of the outcome. So they prevent bias in decisions about whether or not a patient had an outcome of interest or not. The final group will be the data analysts. So data analysts, so that they are not biased regarding data analysis during that decisions when they take, so they should not be biased. So these are the five groups of people who should be possibly blinded to treatment assignment. So this thing must be kept. So in what are the is groups which are blinded, that must be noted. So and subsequently, where the groups prognostically balanced at the study's completion. So it is possible that this for investigators to effectively conceal and blind treatment assignment and still fail to achieve an unbiased result. So how to prevent this? So whether to see this or not, and then finally the question which you ask will be whether the follow-up of these patients are complete or not. Usually the patients will be the greater the number of patients whose outcome is unknown, the patients lost to follow-up, the more the study is potentially compromised. So the reason that the patients who are lost to follow-up often have different purposes from those who are retained. So the magnitude of the bias may be substantial. So the thing is, we might think that the number of follow-up patients might be insignificant, might be significant. Sometimes it might be significantly more. Now, how does it affect the results of the trial? How does it bias the results of the trial? For example, we take two scenarios, two trials, trial A, trial B. So trial A, the treatment group would be 1,000, control group would be 1,000. Again, trial B, treatment 1,000, control 1,000. So number of patients in trial A totally will be 2,000, trial B also 2,000. The number of percentage lost to follow up in both the groups will be 30 in treatment group, 30 in control group in trial A, and 30 treatment group, 30 control group in trial B. So totally 60 patients were lost to follow up in trial A and 60 patients were lost to follow up in trial B. So number of deaths will be in treatment group is 200 and control group in 400 in trial A. The relative risk not counting patients lost to follow up will be, obviously it will be zero point 0.2 by zero point 0.4, which is 0.5, right? So in trial B, we take the number of patients who are dead in treatment group will be 30 and in control group will be 60. So here the relative risk will be 0.03 by 0.06, which is 0.5, right? So the relative risk for worst case scenario will be 0.23 by zero point 0.4, which will be 0.58, and 0.06 by zero point 0.06, again it will be 1. So the worst, what does the worst case scenario assume? The worst case scenario assumes that all patients allocated to the treatment group and lost to follow-up died, and all patients allocated to the control group and lost to follow-up survived. So this will show that how much discrepancy is there. Thus, the loss to follow-up may substantially increase the risk of bias. So that is why, if assuming a worst case scenario, as I said before, does not change the inferences arising from the study results, then loss to follow-up is unlikely a problem. If such an assumption would significantly alter the results, the extent of the bias is introduced again depends on how likely it is that the treatment patients lost a follow-up very badly, whereas control group lost a follow-up very well. So that decision is actually a matter of judgment. So then the question which we encounter will be whether the trial was stopped too early or not. Stopping trials early, so that is before enrolling the planned sample size, when one sees as an apparent large benefit, is risky and may compromise randomization, because these stopped trials run the risk of greatly overestimating the treatment effect. A trial designed with too short a follow-up also may compromise crucial information that adequate length of follow-up would reveal. For example, consider a trial that randomly assigned patients with an abdominal aortic aneurysm to either an open surgical repair or endovascular repair. So at the end of a 30-day follow-up, mortality was significantly lower in the endovascular group. The relative risk reduction being 0.61, 95% confidence interval, being 0.13 to 0.82. The investigators followed the participants for an additional 2 years and found that there was no difference in the mortality between two groups after the first year. So the 30-day mortality, which initially revealed a result, so that might be, again, the result might be altered if the patient follows up in almost a span of 1 year. So if the trial had ended earlier, the endovascular therapy might be considered substantially better than the open surgical therapy. That is why the premature ending of the trial might be harmful rather than beneficial in a few trials. So then subsequently, coming to the next question, so were the patients which are analyzed in the groups to which they were randomized or not? So investigators usually will undermine the benefits of randomization if they omit from the analysis patients who do not receive their assigned treatment, or worse yet, to count events that occur in non-adherent patients. Such analysis will bias the results. Yes, the reasons for non-adherence are related to prognosis. So the another concept which we should understand will be the intention to treat principle, ITT. So what is ITT? So when adhering patients are destined to have a better outcome, omitting those who do not receive assigned treatment undermines the unbiased comparison provided by randomization. Investigators prevent this bias when they follow the intention to treat principle. So uh, following the intention to treat principle, however, does not reduce the bias which is associated with the lost follow-up. So that is different. This is different. Now, you remember the previous scenario which we encountered, that elderly male with a diabetic male, hypertensive male, who comes with the pain and still he wants to improve the functional outcome. So we filtered the ACP website and we found 7 articles. Finally, we narrowed down to one particular article which enrolled 212 patients, randomized 212 patients. So coming to that study, so the study was randomized and allocation was conceived. So that thing we ensured. 212 patients participated, right? And how many patients were followed up? 95% of the patients were followed up. So the investigators followed which principle? The investigators followed the intention to treat principle. They included all patients they had followed up in the arm to which they were randomized and stopped when they reached the planned sample size. There were more patients who had occlusive disease, arterial disease in the ramipril group. This finding could bias the results in favor of the placebo group, and the investigators do not provide an adjusted analysis for the baseline differences. Clinicians, patients, data collectors, outcome assessors, and data analysts were all blinded to that allocation. The final risk of bias assessment represents a continuum from the studies that are at a very low risk of bias to others that are very high risk of bias, yielding a biased estimate of effect. Inevitably, where a study lies in a continuum involves some judgment. In this case, despite uncertainty about the baseline differences between these groups, we conclude that the risk of bias is low. So this will be the discussion of the first division. That is, you analyze the article completely. So what are the parts of analysis? How they have randomized? How many patients they have randomized? How they are followed up? What proportion of the original samples was followed up? And what principle was followed up? Intention to treat was followed up in this case. And then over how long they were followed up, what is the risk of bias, and how do you estimate the risk of bias? And for this study, the risk of bias is low despite the probability that these two groups with the differences are not adjusted. And now finally we come to the second division. What are the results of this study? So how large was the treatment effect? So you should know that most frequently RCTs monitor dichotomous outcomes, that is yes or no, whether cancer has happened or not, whether myocardial infarction has happened or not, whether death has happened or not. So patients either have such an event or they do not. And the article reports the proportion of patients who develop such events. That is the usual reporting. Actually reports a dichotomous outcome. Consider, for example, a study in which 20% of the control group died, but only 15% of those receiving a new treatment died. How might one express these results? So one possibility will be the absolute risk difference or the risk difference, absolute risk reduction, ARR, between the proportion who died in the control group and the proportion who died in the experimental group. So we have a control group risk score or risk number, we have the experimental group risk number. So as I told before, 20% of the control group died, 15% new treatment died. So 20% is 2.2, 15% is 0.15. So 0.2 minus 0.15 will be 0.05. So the other way, that is you subtract to get the absolute risk reduction. So from that main number, which is who died in the control group, there's only 5%, that is 0.05. So that is called as absolute risk reduction score or the risk difference. Okay, so if you plot it in a box, so usually if you plot it in a blocks, for example, uh, X and Y. So for example, the treatment control, the death, the survival. So treatment group, how many people have died? 15. Control group, how many people have died? 20. The remaining group is will be 85 in the treatment group and 80 in the control group, to a total of 100 in treatment and 100 in control each. Okay, so the control group risk will be 20%, the experimental group risk will be 15%. You subtract it, you will get the absolute risk reductions or the risk difference score. So that is 5%. So how will you calculate the relative risk? And how will you calculate the relative risk reduction? So this comes under a lot of statistics stuff. And the relative risk will be EGR by CGR, that is experimental group risk divided by control group risk. That is 15 by 100, the whole you divided it by 20 by 100, that is 0.15 by 0.2 into 100%. So how much that accounts to? If you convert everything into percentage, that will be much more easier. So then that will come as 15 by 20 into 100. So 15 by 20 into 100 will be around 75%. So the relative risk reduction will be 1 minus 75%. So 1 minus 75% into 100%. So that will give a percentage estimate. So that will come, obviously the remaining relative risk reduction, the reduction fraction will be the 25%. So these are the results from a hypothetical randomized control trial. So how the risk factors are reduced. So now we have examined how to analyze the risk, analyze the results of a randomized control trial. Fine. So investigators may compute the relative risk during a specified period. So during that specific period, what is the relative risk? So this is called a survival analysis. The relative measure of effect in such a time to event analysis will be called as the hazard ratio. So when the people do not specify whether they are talking about the relative risk reduction or absolute risk reduction, for instance, drug X was 30% effective in reducing the risk of death, or the efficacy of the vaccine was 92%, they are almost invariably talking about the relative risk reduction. So usually we see such studies, sometimes they comment that the efficacy of the vaccine was 92%, for example, and for example, the other example, the drug X or Y was 30% effective in reducing the risk of death. So what do they mean? They mean that invariably they are talking about relative risk reduction. That thing you should remember. Okay, fine. Then finally, how precise was the estimate of the treatment effect? So we have seen how to measure the treatment effect. Now, how precise was the estimate of the treatment effect? So we can never be sure that the true risk reduction. The best estimate of the true treatment effect is what we observe in a well-designed randomized trial. This is called as the point estimate. So, which means the true value lies somewhere in its neighborhood. It is unlikely to be precisely correct. So that is why we use the term point estimate. So, investigators usually tell us the neighborhood within which the true effect lies by calculating the confidence intervals, the range of values within which you can be so and so confident. For example, if 95% confidence, 95% sure that whatever value you say falls within the range. So that is the meaning of the confidence interval. That is why usually the researchers use the 95% confidence level. So how much confident you are, sure you are that that value which you say is within that interval, right? So so the true relative risk reduction will generally lie beyond these extremes. Only 5% of the time a property of the confidence interval that relates closely to the conventional level of statistical significance of p-value less than 0.05. So we this can be again can be checked in multiple trials and all those things. So this basically uh, this is the second part of the uh, analysis of an article. So how do you do that? So the third part will be continued in the next video. Thank you.